ADHD is classified as a neurodevelopmental disorder. And so a lot of times I think one of the biggest challenges in my work with kids and families with ADHD is often we feel like it's a choice when kids are acting out. And we really want to reconceptualize ADHD as actually a difference in how the brain functions. And so kids or adults or teens who have ADHD are not choosing to act in this way, but these are some common deficits that are associated with ADHD. And we know the two sort of hallmark types of ADHD are what we call inattentive type and hyperactive or hyperactive and impulsive type ADHD. So the kids who have inattentive type ADHD are kids who might be making careless mistakes, like if they're completing schoolwork, maybe they are missing every other question, or they're not checking over their work, or they're filling in an answer bubble that doesn't correspond to the actual question that they're answering. They might have a hard time focusing, and this is above and beyond sort of typical kids their age. So these are the kids in class who the teacher might be constantly saying, pay attention, or are you listening? They might be getting in trouble for having a hard time focusing and getting really easily distracted. Again, for instance, maybe if the teacher is, talking to another kid or helping them with their homework, a kid who has inattentive type ADHD might be super focused on that side conversation and struggle to continue to complete their work independently. It also might be a kid who, if you as a caregiver say, they just tune me out, I have to ask them 100 times, doesn't seem like they're listening, and they're just constantly, I'm buying 3 new winter jackets every season. They're losing things. They have a hard time keeping track of their belongings. Those are some of the common things that we see with kids who have this sort of inattentive type of ADHD. We also think about hyperactive and impulsivity. And these are the kids, this is sort of the hallmark, category of kids. So the kids who are sort of fidgeting, running around, maybe you feel like they're driven by a motor, they're like a little energy bunny. Maybe they really need someone to sit next to them while they're doing work or while they're playing. And these might be kids who sort of talk nonstop and interrupt and really have a hard time taking turns. So when we think about kids with ADHD, we're thinking about, do they have only inattentive type symptoms? Do they have only hyperactive and impulsivity symptoms? Or do they have what we call combined presentation, where they have substantial symptoms in both categories? These are sort of our clinical terms, but we wanted to put this into sort of real person terms for you as well. So if you're a parent or if you're a clinician, here are some of the things you might see or hear about frequently. My kid might vacillate from really, really intense emotions, or maybe their response seems sort of exaggerated to the situation. Again, children who have a hard time following instructions. So I often hear parents say they only listen, the 9th or 10th time I tell them to. Maybe they're getting into trouble at school because they're not following directions, or they're losing track of their work because they only get the first couple of steps of directions, but not the whole set. And these are kids, again, who are categorized by more impulsivity than most children compared to, in their age. So, kids who might not think through the consequences of their actions, or who have like really poor time management skills. Maybe they think that worksheet's only going to take them 15 minutes, and then they sit down to do it, and it's actually going to take 30 minutes of sustained attention. These often are also kids who have a hard time getting started on tasks, especially tasks that are less preferred or tasks that are really difficult. So you might say, my kid is a big procrastinator. Anytime it's time to sit down and do homework, or especially with Zoom school, time to sit down and do, sort of virtual school can be a real challenge or a real fight. And we also know that kids who have ADHD, one of the core features of ADHD is that it's really difficult for them to sustain their attention on tasks that are particularly challenging. So this might look for you like sort of difficulty persevering, particularly again on hard tasks, or really big behaviors to avoid having to do something that's particularly challenging. We know that transitions can also be really disruptive and hard for kiddos with ADHD. So I'm sure, for many of you, the start to the school year is often a time that's really challenging for our kids. And this is especially compounded with telehealth. And we know that they can be really focused. I think attention deficit disorder is almost a misnomer because kids with ADHD often are very able to focus on the things they like. They often just have a hard time switching sets and focusing on something that's more challenging for them. Anything to add in here, Christopher?
Well, you just froze briefly, and I don't know whether it was just on my end or not, but I do think that because these symptoms are kind of so universal, is really important. And what we look for is a divergence from where we would expect a child of age 6 or a child of age 8 or a child of age 10 or 12 to be able to focus their attention, sustain their attention, even for non-preferred activities. And that helps us to delineate when it becomes functionally impairing. And ultimately, that's really the bottom line is this getting in the way of this child making success that they might otherwise be able to make given their cognitive and learning style?
Exactly. So when we're looking at all of these symptoms, these are going to be things that are typical for most children at certain times, but is it sort of pervasive and is it getting in the way enough where they can't sort of succeed to capacity because of some of these symptoms? All right, so just a little bit more information about ADHD, and we're going to get to diagnosis in just a minute because I think what Christopher is saying really ties into that. But ADHD is an incredibly sort of prevalent disorder. So we know that between about 8 and 10% of children in the United States are diagnosed with ADHD. That's about 5 million children per year. So really a substantial number of children. But because that this disorder impairs functioning across a number of settings at home, at school, recreational activities, even though there are other disorders like anxiety or depression that have higher prevalence rates, ADHD is one of the number one reasons why kids get picked up for school-related difficulties or behavioral challenges at home. So a high number of the kids who come into treatment in outpatient level of care and also school-based care are going to have problems associated with ADHD. Okay. We also know that ADHD has what we call a life course disorder. So this is not something that typically kids grow out of or just goes away. This is something that typically is sustained through adulthood because it's a difference in how sort of the brain is wired and functions. So that really talks about the importance of early intervention and treatment, because we know that we really want to get sort of the supports in place, because this is going to be something that we want a child to understand how to sort of learn how to function successfully with. In terms of what we call comorbidity or co-occurrence, boys, we really think a lot about sort of the socialization of ADHD. So we tend to see boys have more of that hyperactive impulse control challenge with ADHD and are often co-diagnosed with oppositional defiant disorder or other disruptive behavior disorder challenges. Girls can also be diagnosed with other oppositional defiant disorder diagnoses as well, but they're more likely to display sort of inattentive type ADHD and to also present with symptoms of anxiety and depression. In terms of the diagnosis of ADHD, there's actually quite a lot of thinking around the diagnosis of ADHD, and the sort of gold standard diagnosis is what we call a comprehensive sort of multimodal assessment. So this is going to be data from multiple sources, again, because ADHD doesn't typically only show up in one setting. It's how the brain is wired and functions. So we want to make sure that we're gathering data from school, from recreational settings like sports teams or different groups that the kid goes to, also from home, to make sure that we're seeing a consistent presentation across settings, or if there isn't a consistent presentation, why? Okay, maybe sometimes in school where there's tons of structure, kids do a little bit better than the home environment where there might be a little bit less structure. And that's going to be really helpful for us when we're thinking about treatment and different recommendations. We want to make sure that we're doing a good medical exam. So oftentimes it's actually the pediatrician who is the first person to assess a kid for ADHD. And sometimes that's sufficient. A pediatrician might do a couple questionnaires, gather some information and say, I really think your kid is meeting criteria for ADHD. Sometimes they will send them to someone like me in an outpatient world and do more of a semi-structured diagnostic interview. And we would also do questionnaires to support that diagnostic interview. And then sometimes we're even going a step further and we are referring for a neuropsych evaluation where we have a neuropsychologist do some additional measures, like something called a continuous performance test that helps sort of with that gold standard comprehensive ADHD evaluation.
And Sarah, we had one question submitted by one of our participants before the recording about whether or not you're still able to get testing for ADHD during the pandemic, and whether or not that's something that can happen either remotely or in some hybrid way.
Yeah, so it's a really great question. You know, so far at our clinic at CECT, we are doing diagnostic evaluations remotely. And, you know, so far we've had pretty good success. So we do a semi-structured interview. We spend about 90 minutes with the child doing a diagnostic interview, going through what we call DSM criteria. So that's our manual for diagnosing. And we go through different diagnostic criteria for ADHD and also for a number of other emotional and behavioral disorders to help us rule out anything else that might be going on. We do that with the child, and then we do that with the parent. And we also have kids and caregivers complete questionnaires that give us information, again, sort of about the child compared to other kids their age. So we've been able to do that really nicely over telehealth. And you can imagine, even if a kid is doing a 90-minute interview, we get a lot of opportunity to observe symptoms of ADHD. You know, are they able to sit down and attend to the interview? Are they able to answer our questions? Are they sort of rushing through them? Are they getting out of their seat? Do they need a lot of fidgets in order to complete the task? So that gives us a lot of helpful information. I think neuropsychologists are having a little bit more challenge in doing telehealth assessments because oftentimes when they do an assessment, it requires the participant to interact with different tools that they have. So for instance, something called the continuous performance test is actually an application that a kid will do, and they'll have to press different buttons on the computer screen. So I think something like that would be more difficult to do over telehealth. So if you're thinking my kid might have ADHD, I really want to start the evaluation process, what I would probably recommend is trying to do a diagnostic interview, like some of the ones we offer here at Judge Baker first. And then if your clinician thinks that a neuropsych, a more in-depth evaluation is required, I'd recommend getting on the list now, because I think these places often have long waiting lists, and hopefully in a couple of months, we'll have more capacity to start doing more in-person assessments. I know many centers are starting to open up for in-person assessments gradually.
And I would just add that the rating scales that you've described are also great to show progress in response to treatment. So some psychological test batteries really can't be repeated more frequently than every year. With the rating scales, those are actually designed to be a way of tracking the response to the intervention, whether it's a medication intervention or a therapeutic intervention.
That's exactly right. So when we do all of this work at the assessment, we get a sense of where the kid is at their baseline, and then we make good treatment recommendations. And that's what we want to talk a little bit about today. So, you know, when the American Academy of Pediatrics and the Society for Developmental Behavioral Pediatricians also updated the clinical practice guidelines for ADHD this past year. And really the recommendations for ADHD treatment are behavioral therapy. Okay, so what does that actually mean? That means that it's going to be comprised of a couple different components. The first is what we call psychoeducation about ADHD. So just like how we spent a couple minutes this morning talking to you about many of the symptoms of ADHD and sort of what goes on in the ADHD brain, that's a lot of what ADHD treatment entails. And as you can imagine, this is going to be more targeted towards teens or caregivers, because young kids with ADHD are going to have a relatively challenging time kind of soaking in this information and applying it. But we want to make sure that we're having a conversation with kids about how their brain works differently, because they're already probably picking up that there's something a little bit different from them than how their peers operate. So we love to provide a lot of education about ADHD in the brain. And then the primary recommendation for treatment is actually what we call parent training or behavioral parent training. So often because kids with ADHD, their frontal lobes, which allow them to sort of plan, organize, inhibit their behaviors, they're really not developed until kids enter their teen years and really beyond into early adulthood. So we like to use a lot of the adults in the child's life, both caregivers and school-based providers, to infuse treatment early in their life. So parent training is going to really be comprised of positive reinforcement strategies where kids get a lot of praise for sort of appropriate positive behaviors that we like and want to see more of. So they get a lot of that positive attention and start to learn what gets them positive attention and what sorts of behaviors, sort of lead to more unwanted consequences. We also think a lot about classroom management. So many kids with ADHD, they're going to qualify for special education services. This could be through what we call an individualized education plan or a 504 plan. And there are a lot of interventions that are available in the classroom that can allow kids to be more successful. As kids get older, we start to think more about peer-based interventions like social skills groups or organizational skills training to help them plan and prepare for their schoolwork, going through their academic planners, making sure they've written down all the work, making sure that they have a good sense of how long work will take them to complete and what tools they need to complete that work. But really, when we're thinking about kids in the elementary and middle school stages, we're thinking primarily about behavioral parent and school-based recommendations. And of course, medication is a big part of ADHD treatment as well. So I'm going to turn it over to Christopher there.
And before we do, there were two questions that came in before this session went live. And one was, is teletherapy just as good as in person? So how is that working as we're doing so much of this work remotely now in terms of behavioral parent training?
Yeah, and so that's a fantastic question. And, I think I have learned so much about telehealth in the course of the pandemic, because I think it was something we were really nervous about as a clinical team, and that we've been actually really surprised by how successful the transition to telehealth has been. And again, because ADHD interventions are typically parent or caregiver based, we've seen that the treatments have converted really, really nicely to telehealth, because we're not actually asking the child to sit down in front of the video screen and talk to me about all the times that they couldn't pay attention or sort of, did things and maybe got in a little trouble for it this week. We're just working with the caregivers to learn a specific set of tools and then, sort of practice those tools and think about how to implement them at home throughout the week. So I think telehealth has actually converted really, really nicely. It allows you, maybe if you and your partner are both at work, maybe in different physical spaces, you can both Zoom into a meeting. It's also been really nice for me because I've gotten sort of tours of people's homes and gotten to see where you actually live and where some of these skills are going to be implemented and utilized. So it allows us to really do some more environmental control and problem solving. And we've had families who've actually said, can we stay in telehealth even when, services do resume in person? So I think there's a lot of barriers and obstacles that telehealth has really nicely addressed. So if you're skeptical, we definitely encourage you, to sort of expand your thinking a little bit and test it out, because it's been really helpful thus far.
Two more questions. So another one was, how do I talk to my son's teachers about ADHD?
Yeah, so I think, this can be really hard, and, Christopher, chime in if you have any suggestions as well, but I think it really depends on how the conversation is unfolding. A lot of times I think teachers might be the ones starting the conversation about ADHD because they are noticing a challenge in the academic environment. So perhaps they're saying, the kid just really can't stay in their seat, or they're interrupting a lot, or they're not turning in any of their homework. And if the teacher is really identifying these challenges, there's a couple of things that you can think about from a caregiver or clinician perspective. The first is that every kid has the right to be evaluated by the special education department at their school if they go to a public school. So if the teacher is raising concerns about the child's symptoms impacting their academic achievement and their progress in the classroom, you can say, I'd like to request a special education evaluation. And you would want to really put that in writing so the request is formally documented. And then the school will do a special education evaluation where they will have the school psychologist and a number of other providers evaluate the child and understand a little bit more about their sort of cognitive profile and what might be occurring. A school is not typically able to diagnose ADHD, so they might in tandem say, we want you to get an outside evaluation and see if there's anything else that's going on here. So that's, again, a time you might call someone like myself or another outpatient center or a neuropsychologist and see if they could do a diagnostic workup while the school is doing a special education evaluation. If your kid already has ADHD and you're aware of it, and maybe school hasn't said anything to you about challenges in school, this is maybe a different conversation that you want to have with the teachers, where you might be saying, how's my kid doing? Are there any challenges that are going on? And you can kind of decide, is this something I want to share with the teacher? Or is this something that I want to keep, sort of more private? I think if you do decide to share the ADHD diagnosis, again, we think more information is helpful, and we think sort of talking about ADHD allows it to be destigmatized, but you might, sort of educate the teacher about some of the strategies that are really successful for working with your kids. So oftentimes kids with ADHD are going to be really sensitive and susceptible to negative feedback. So if they hear no or don't or stop it, a lot of times we see those behavior problems really escalate, because a lot of times they don't mean to be acting out. And so when they get that negative attention, it's sort of a reminder for them, I'm looking or acting differently than some of my peers. And that can lead to a lot of anxiety and distress. So we might talk to the teachers about front loading a ton of positive attention, or what we like to say, sort of catching kids being good. So if a kid's getting out of their seat a lot, maybe the teacher sort of has an aid or a reminder that every time the kid's sitting nicely in their seat, they're kind of given like a thumbs up or saying, nice job staying seated, and sort of front loading the teacher with some strategies to catch the kid being good. Also thinking about maybe some additional strategies like, giving them a gentle tap, making sure that they have written down all the steps for an assignment that they have, checking their planner to make sure that all the information is accurately recorded. So there are some really, really simple interventions, even preferred seating, that teachers can include, even without any types of special education services, which are going to make it more likely that that child's successful. And then I think, I just add in sort of consultation and communication with any outside treatment team that's involved. Teachers have so much on their plates to manage. They have tons of academic instruction that they're tasked with, sort of imparting to all of our kiddos. And so it's really the job of the mental health professionals to know sort of how to support kids in schools with appropriate interventions. So, no need to make that teacher work more than they need to, when we can also, jump in and offer some suggestions and strategies that we've seen be successful time and time again.
So one more before we switch to medication, and we will get there. So there was a question in the chat: is a child born with ADHD, or is it impacted by being raised by a parent with untreated mental health issues like anxiety or depression, or in a traumatic home environment?
Wow, so this is a really big question, Judy, and something that we actually think a lot about in our field, because oftentimes one of the challenges when kids come in for an evaluation, especially if they are maybe going to their pediatrician and the caregiver's describing some symptoms of ADHD, oftentimes we think, oh, that must be ADHD, and we don't do a further diagnostic workup. And so this is where that sort of assessment is really, really important, because ADHD can look a lot like trauma. And symptoms of PTSD, especially in young children, are going to look like inattention, are going to look like sort of big mood swings or irritability, difficulty following attention, so paying attention. So we really, really want to do that good diagnostic workup first, because if there's something else going on, like traumatic stress or anxiety or depression, we can put all of our resources into treating ADHD, and we're not really going to see a ton of success. So I think, good assessment is the key to a good treatment plan and pathway. Because ADHD, again, is really a neurodevelopmental disorder that's about how the brain is wired and how the brain functions. But things like anxiety, depression, trauma can look a lot like ADHD. But ADHD is not going to be caused by those things.
Great. Okay, let's get to medication.
Excellent.
Next slide.
All right, Christopher.
So we thought we'd talk a little bit about some medication myths. So if I put my child on a medication, they will become a zombie is one concern. And while the medication class that we use most commonly for ADHD are actually called stimulants, obviously we don't want to stimulate an already hyperactive child. And what we're really talking about here is that ADHD is a problem of selective attention, just like Dr. Sarah was talking about. And what the stimulants appear to be able to do is actually focus that attention more effectively. Whereas a child with ADHD might be focused on attention, but for very short periods of time, or when we're trying to get them to focus on non-preferred activity. So as Dr. Tannenbaum has already said, they can often engage in a preferred activity, a toy, even an online game for hours. And that doesn't mean that your child doesn't have ADHD. It's really when we're asking them to focus on things that they may not want to focus on, or making that shift from a preferred activity to a non-preferred activity that really can be problems. So I would say the answer to this is false, and that really the art of medicating a child with ADHD really is about finding the right dose and minimizing the potential side effects, which for the stimulant medications are most commonly appetite suppression, which can lead to weight loss, or if you take it too late in the day, it can impair the child's ability to sleep. But if you're dosing it properly, you should be able to get the maximum benefits with the minimum of side effects. I never say that you won't ever have side effects, but the art is then finding the right combination and the right dosing. And stimulant medication is one that's in and out of your system within the day. It's very fast acting. And so some parents even decide that they may just want the effects of the medication to occur during the school day, and that they feel like they can support the child doing homework or any after school activities. Now in a Zooming world, I'm guessing that that equation may change, but some parents will give weekends without the medication. It really would also depend on just how impaired your child or impairing your child's ADHD is for them, whether or not you make the decision to give it 7 days a week versus just on school days, et cetera. And also if they're tolerating it well, you may not want to have that kind of disruption in the delivery of the medication by giving them weekends without the medication. So the next slide.
Christopher, I was just going to add in one thing, about our summer camp program, because one of the things that I think has been super interesting for me is in our summer treatment program, we run a really, really structured day where we give a lot of points and positive reinforcement for appropriate behavior. And we have really structured disciplinary strategies anytime we see sort of the unwanted symptoms associated with ADHD. And a lot of our kids and families will sort of take a medication holiday over the course of the summer treatment program because the day is so structured. And we've actually seen a lot of kids have pretty substantial success. We ask that caregivers kind of talk to us before they take that medication holiday, so we make sure the kids really learning the rules and the structure and able to participate in the program before we try the holiday. But we've seen kids for the last 4 weeks of the 6-week summer camp be really successful off medication with those additional structures and supports in place.
It's a great point. Medications, particularly for behavioral health conditions like ADHD, they're not antibiotics. They're not going to cure the condition. So whether it's anxiety, depression, ADHD, post-traumatic stress disorder, any of the behavioral health disorders, the medication can reduce the symptoms, but it doesn't ultimately make the underlying condition go away. And that's particularly true for ADHD. And what I like to say is medications don't teach skills. And so medication should rarely be used in isolation of all the kinds of interventions that you're talking about, Sarah. And ideally, if the child can learn those skills, they may be able to manage their condition on less medication or perhaps even no medication. And that's particularly true for ADHD, where, when I'm working with adolescents who are diagnosed with ADHD and talking about going to college or post-secondary employment, I want to have a conversation with them about how they're going to use the medication to treat their condition, because it's going to be different for different individuals. And what we see with ADHD is that some of the hyperactivity burns itself out into adulthood, but the impulsivity can still be there, and certainly the inattention. And that can be very impairing into adulthood. Studies of adults with ADHD show greater challenges in successful long-term employment, sometimes in interpersonal relationships, et cetera, higher accident rates, those sorts of things. So we want to make sure that if the medication is supporting them, even after they've had good behavioral interventions and those skills have been taught, some individuals are going to decide to stay on the medication for a longer period of time, particularly if they're not having side effects. So it really depends. It's on a case-by-case basis, which I think may have already answered one of our next questions, but why don't you go ahead and put that up?
It did. All right. Well, here we go.
So starting my child on medication will be a process, and they may need to change doses, and that's absolutely true. And again, it's a little bit trial and error, and that doesn't mean that the person who you're working with who's making the prescribing, whether it's your pediatrician or a behavioral health specialist who has prescribing authority, doesn't mean that they don't know what they're doing. It just takes that kind of individualizing dose. And so what we try to do is start low and go slow. So we start at a low dose and then advance the dose slowly to see what's going to be that sweet spot where you're getting the maximum benefit with the minimum of side effects. And that's a trial and error approach. There's no way to predetermine what that dose is going to look like for any particular child. For the stimulant class of medication called methylphenidate, or it's more commonly known as Ritalin, the dosing guideline is about 1 milligram per kilogram of body weight. But there's still great variability. And then for the amphetamine-based products like Adderall or Vyvanse, it's about half that. So that's a rough ballpark. You have to convert weights to kilogram and then figure out the milligram per kilogram dose. And that's a daily. So often these medications, because they're pretty short acting, have to be given multiple times a day. And so that would be the total daily dose. And the next question. And this is what I was just referring to earlier. So if I start medication, my child will have to be medicated forever. And again, that's not true. So that would be false. And that doesn't mean that some individuals won't choose to stay on the medication into adulthood. Again, particularly if they're having good success. When I'm working with children who are heading off to college, I'll say, let's not stop the medication just as you're starting this new learning environment. But college classes can sometimes only be on Tuesdays or Wednesdays. They may pack their schedule and get all their learning done on those days. That may be when they want to take the medication, or they may want to take it when they're doing a big project or they're studying, because they find they have a harder time focusing their attention and they're less effective or efficient in their studying. So if you're hearing that kind of thing and your child has decided to go off their medication, it might be time to have a conversation about them going back on the medication.
Christopher, we got a question in the chat. How does a provider determine what type of medication to recommend for a child with ADHD?
Yeah, I like the longer acting medications. There's a lot less rebound hyperactivity. So one of the things that you can sometimes see with the shorter acting medicines is that it works really well while the child is on the medicine, but when they come off of it, they don't just go back to their unmedicated state. They actually have rebound hyperactivity where they look even worse. And so the longer medication duration, a medicine like Concerta, which is a type of Ritalin-based product that has Ritalin short-acting on the outside, so you get that immediate effect, and then it has Ritalin in encapsulated form inside of the capsule. So as the stomach digests the capsule, it's actually replicating a 3 times a day dosing. So it really depends. Now, I may start initially with one of the short-acting medicines just to see as a trial balloon, how is this person going to respond to the medication? And then if we have good effect, I might then switch them to a longer acting. And it depends again, if I have an issue with appetite suppression, I may not want them on a longer acting because I may want them eating between doses. And this way they keep their weight on. So it's a little bit of the art of medicating a child with ADHD.
Christopher, we have another question talking a little bit about some of the extensive wait lists to get formally diagnosed for ADHD, often being between 6 months to a year. So this person asks, if a child is in real distress and has been informally diagnosed, is there a way to speed up the process to get the child medicated?
Yeah, I mean, there are many individuals, particularly pediatricians, who will prescribe without a formal neuropsychological test battery or someone else making a formal diagnosis. The rating scales are often quite useful, particularly if you get them completed by both the parent and the teacher. Now, I've heard some challenges because so much of teaching in many districts is happening remotely. It's a little harder for the teacher to be able to assess the child's attention, particularly if they have not known the child before a remote learning environment. In that circumstance, you might want to circle back to some of the past teachers who had the experience of working with that child in class. If their child has ADHD, those teachers will remember that child often and can still fill out the rating scale, even though it's meant to be done in real time.
So we're going to talk a little bit more about what we call medication sequencing or treatment sequencing. But we do have a question that's asking, what's the difference between ADHD and ADD? And this is a great question that we as a field have not done a good job of spreading information about. So happy to have this venue to do that today. So ADD is sort of the old name for ADHD. Our diagnostic manual is updated about every 10 years or so. And it used to be called ADD in former versions of our manual and was updated to include the hyperactivity component of the diagnosis. So ADHD and ADD are synonymous, but the correct terminology is now attention deficit hyperactivity disorder.
Yeah, sometimes I think people are making that distinction you made earlier about impulsivity and hyperactivity happening kind of together and call that ADHD. And sometimes if you only have the inattention component, sometimes people will call that ADD. But you're right, Sarah. I mean, it's really ADHD combined type, or do you have just the inattentive type or the hyperactive impulsive type, or the combination?
Yeah, exactly. So I do see some more questions in the chat asking for tip sheets and other recommendations for adding in more structure in the day. And Alex, perhaps you can help with that. We do have a resource page. And if you go to campbaker.org, or if you go to the Judge Baker Facebook page, I think all of our resources are on there. Give a little shout out to our postdoctoral fellow, Leah Guterman, who's on the call right now. She's made a ton of wonderful tip sheets and materials for us that have a lot of different resources about ADHD. So definitely encourage you to check some of those out. So this next slide is about what we call treatment sequencing. And so that was a big thing that was updated in these new clinical practice guidelines, because you can imagine, if your kid has ADHD and you're having some struggles with your child in a lot of different settings, you probably want to try like everything you can to get this problem under control as quickly as possible. And we completely understand that. We know how problematic these behavioral challenges can be and these learning challenges can be. But what we really, really want to sort of impart to you is sort of that phrase that Christopher said, that medication does not teach skills. And so a lot of times there's a big rush to get kids medicated, but often that's the only treatment that they actually receive. And so the American Academy of Pediatrics guidelines really say, hey, medication can be awesome, but first we really want to try our psychosocial interventions because that might be enough to get a lot of these problems under control. And if you don't need to medicate your kid, or if you can take a lower dose because you've got some really good behavioral supports in place, I think we all would recommend sort of the least medication necessary to address the challenges that the kid is presenting with. So again, behavioral parent training is going to be that primary recommendation for young children. And that can have a lot of different names. So behavioral parent training is sort of an umbrella term that is going to include interventions like parent-child interaction therapy, or PCIT, which is offered here at Judge Baker, as well as a number of other different outpatient treatment centers. And then behavioral parent training is also sometimes called parent management training. They're synonymous terms that are really, really effective parent-only interventions where caregivers learn the information about ADHD and related behavioral challenges. They learn the tools, and then they practice implementing those tools at home with their child. Classroom interventions are going to be really similar. So again, that's teaching classroom teachers about ADHD and making sure that they're using complementary interventions, thinking about positive reinforcement strategies, and really structured, consistent disciplinary strategies for managing behavior in the classroom. When kids get a little bit older, we still want to use those behavioral parent training and classroom interventions. But as kids get into those preteen and teen years and they're more able to be involved in their own treatment because their brain is developing, that's when we start to include more things like organizational skills training. I have medication here. It's not that medication can't be used for young children, but especially for young children, we want to first try the psychosocial interventions before adding medication in. I think unless the problem is so severe that it needs medication to access those treatments. Would you say that's right, Christopher?
Yes, absolutely. I mean, if I have a child who's literally being expelled from preschools, that might factor into my deciding. And some of these medications are approved as low as age 3, but obviously we want to be really thoughtful about the use of medication in children that young.
And again, those rating scales that we take in the beginning of treatment, we're going to be constantly looking at, because if you as a caregiver or the teacher are saying, hey, these problems are not interfering as much, the intervention's actually working, that might be someone like myself and Christopher working in tandem to say, we're going to reduce the medication dose because the caregivers feel a lot more able to address these problems without just the medication alone. All right. So we've talked about this a little bit already, but as we mentioned, ADHD is really considered sort of a life course disorder. So it's often chronic and persists into adulthood. And so we really want to make sure that we are monitoring ADHD from sort of as early in the lifespan as we notice these problems start to occur. And we want to keep monitoring them as kids develop and transition across many different stages. So those developmental transitions are oftentimes when we see a lot of challenges, when we start kindergarten or when we go from, elementary school to middle school, or Christopher was even talking about when kids launch and go off to college. Those are often going to be times that are transitional challenges for any of us. And so for, children or teens with ADHD, those challenges are going to be even more pronounced. So we want to really think with them about the skills and strategies they've learned in psychosocial treatment interventions. And also one of those skills is taking medication consistently, how they're going to kind of use all those tools to successfully navigate all those transitions, because we know that if untreated, the problems associated with ADHD can be really profound. All right, it looks like there's a question in the chat about a 16-year-old who's self-diagnosed with ADHD. And it looks like he's doing a lot of time on screens, playing video games, and then staying up really late until 3 a.m. doing homework. And there's a big sleep deprivation problem here, and they're wondering if he has ADHD. So could this be an ADHD impulse control issue? So the short answer is probably yes, this could absolutely be something related to ADHD, but we'd really want you to get a good diagnostic assessment and make sure that there's a solid understanding of what the challenge is, because you can imagine if a kid is sleep deprived, they're probably going to present a lot like someone who has ADHD. And there have actually been studies in the Journal of American Medicine that look at just this issue. So when there is sleep deprivation or sort of poor sleep quality, the rates of ADHD diagnosis increase. That doesn't necessarily mean because it's actually a true ADHD diagnosis, but because, if you're sleep deprived or you're getting a poor quality of sleep, you might have to kind of stimulate yourself or be hyperactive just to stay awake and focused throughout the day. So I think we would really want to assess the sleep problem first and make sure that that's adequately addressed in order to sort of do a good differential and figure out if ADHD is really sort of the driver here.
Yeah, and typically ADHD is supposed to be diagnosed before age 12. So it would be unusual to have new onset, not unheard of, but unusual to have new onset at age 16. So I would be curious, when he was home and not attending boarding school and presumably was sleeping well, did you have concerns about him having ADHD then? Because if not, then it probably is more of a sleep disturbance factoring in and causing him to now present like he's got ADHD. But the good news there is if we can figure out a way to get him to stay asleep at night and maybe take the technology away from him, if the boarding school is able to do that, you should see this resolve.
And Christopher, we have another question. Do we find more parents are seeking treatment from medication during the pandemic, since school routines are disrupted and remote learning is required, requiring so many interventions that used to work and are not as effective?
Yeah, it is a great question because, I mean, in some ways, the use of medication is almost a threshold effect. And so medication can be helpful even in situations where previously the child had learned some skills and the parents had learned some skills in how to keep the child focused, but the demands have increased so significantly. So it would be something to at least consider. I would start by making sure that you are using all the skills that you were taught, or if you hadn't had access to a skills-based approach, getting that access now. And then maybe doing some booster sessions if it's been a while to make sure that you're maximizing the behavioral interventions. And then if you're still finding that this new format is just too challenging, getting a medication consult would be appropriate.
And I would just add in, I think a lot of a lot of the caregivers that I work with who have kids with ADHD, I think the challenge in telehealth has been really above and beyond what children with anxiety or depressive disorders have been facing, because to be on Zoom all day long or to have multiple logins or information in all different sources has been really, really challenging. And I know many kids with ADHD actually require a caregiver to sort of sit next to them with them while they participate in school, which is really challenging if you're also working from home. So I think, many of our kids seem to be struggling more in sort of this pandemic virtual school life than, some other types of kids who might be actually thriving in this environment. And so I think there's a ton of advocacy to be done with schools about how challenging it actually is to get kids to participate in school and get schoolwork done in this remote learning world.
In fact, it's even a part of the debate on what's driving the diagnosis rate up. So we are now, in some cases, some surveys are saying 10% of children are being diagnosed with ADHD. And that's a huge increase from what we had seen even a decade ago. And part of that may be that we're asking young people to be much more focused, and we're already dealing with young people who have problems discriminating their attention and focusing discreetly. And I know right now I've got two screens open and like checking email, and that's not a recipe for success for children who already are coming into the game, perhaps with a brain that causes them to have more challenges to focus. And so some of it may be the changing work environment, the changing learning environment that's driving up the numbers.
So I'm mindful of time. The hour has flown by really quickly for me. So thank you all for so many wonderful questions and for active participation, even when you're muted and your video screens are off. Just to summarize, ADHD can present as inattentiveness, as hyperactivity, impulsivity, or sort of a combination of all of those. Often struggles are going to persist into adulthood. So we really want to get in early and intervene with effective evidence-based strategies. And really the key to that is a good comprehensive assessment that drives our treatment recommendations. And again, we know treatment recommendations are going to be a combination of behavioral therapy, psychosocial interventions, and medication. So it's really the combination that we know is the most effective, but we recommend starting first with psychosocial interventions and then assessing medication as needed. If you're wanting to have more of a dialogue with us or where to go to get services, first, we are having a second event just a week from today, which is October 26th on Monday at 5 p.m., where we're going to have some of the caregivers who've participated in our programs, both at CECT and Camp Baker, talk a little bit about their experience going through diagnosis, treatment, and what it's like to parent a child with ADHD. We have openings at our outpatient center, the Center for Effective Child Therapy, where we offer organizational skills training, behavioral parent training, and parent-child interaction therapy. And we also have a summer program, Camp Baker, that's really geared towards supporting children and families of kids with ADHD. So definitely, don't be a stranger and reach out to us if there's any way that we can be helpful during these difficult times. We'll also be making sure to circulate the informational materials that we have about ADHD. So please let us know how we can be helpful.
There was one more question that was submitted that I think is perfectly timed. Are there any support groups for parents and children?
Yeah, so at Camp Baker, we actually, part of our year-round programming is a support group. So we open enrollment for Camp Baker on January 1st, and then we run parent support groups weekly during the summer and then monthly throughout the entire academic year. So part of that Camp Baker programming is 14 parent training sessions. We're also thinking about having a parent support group in our outpatient clinic. So if there's enough interest, definitely send an email to me and we can see if we can get something like that going for people who have not enrolled in Camp Baker yet. All right. Well, if you have any other questions, you can always email cect@jbcc.harvard.edu. I'll put it in the chat. Or you can email Camp Baker. And if not, we hope to see all of you in a week. And thank you so much for joining us.